I chose to talk about long-term management of autoimmune encephalitis. I know that many of the previous lectures touched on the acute management and the diagnosis of autoimmune encephalitis. But I think one of the areas that definitely requires more attention is the long-term management of autoimmune encephalitis and the outpatient care of those patients. As Dr. Probasco mentioned in his lecture recently, a group of us from the Autoimmune Encephalitis Clinicians Network, we put together 2 manuscripts with recommendations on the management of autoimmune encephalitis. The first one focused on diagnosis and acute management, and the second one was the harder one, and it was focused on the long-term management, and I will try to touch on this important topic during this presentation. So you are in a dedicated autoimmune encephalitis clinic or a clinical neuroimmunology clinic. You're receiving the patient after they've been discharged from the hospital after the index event of acute autoimmune encephalitis, or you're receiving a referral from a different institution for further or long-term management of someone who's recently been diagnosed with autoimmune encephalitis. So how would you approach this patient? I think the way we think about it is there are 5 important pillars here when you see this patient. The first one is confirm the diagnosis. Is the diagnosis correct? Did this patient really have autoimmune encephalitis? Look at the neuronal antibody panel. How do you interpret this? Is the positive antibody clinically relevant or not? So this is the first and most important step. The second step is management of the immunotherapy. Most of these patients will be discharged on oral prednisone, at least in our institution. They are sometimes on other bridging immunotherapies, and they were told that this will be managed by the outpatient neurologist once you see them. So now you have the patient on prednisone. When will you start the weaning? How fast will you wean this patient? Does this patient need long-term immunosuppressive therapy? Or was this just a monophasic event? These are all evaluations that are not made in the hospital, will be made by the outpatient neurologist in the clinic. Number 3, determining the need and frequency of cancer screening. Do we need to do any further screening for cancer? Most of these patients already received at least one form of cancer screening in the hospital, but do we need to repeat this? And how frequent do we need to do that? The fourth question is management of residual symptoms. Did this patient recover 100%, or do they have any residual symptoms that can impair their quality of life? Can I treat those symptoms? And how do I treat those symptoms in a safe manner in a patient with autoimmune encephalitis while preserving and improving their quality of life? And sometimes you can do this by yourself, and sometimes you need other team members to help you out. And that's the fifth point here, which is referral to members of a multidisciplinary team with experience and interest in managing those complex patients with autoimmune encephalitis. And we'll talk about all this in the next slides. So the first mission is interpretation of the neuronal antibody panel and confirming really that the diagnosis is correct. Keep in mind that not all neuronal antibodies are the same or have the same weight when evaluating autoimmune encephalitis. For example, some antibodies are more clinically relevant, like the onconeuronal antibodies. When you see them in someone with cancer or with high risk for cancer and the picture typical for encephalitis, those antibodies are likely clinically relevant. However, keep in mind that sometimes the antibody can be positive just because the cancer is there, but it wasn't really causing the neurological dysfunction. And we've seen a few cases like this where someone has ovarian cancer, they were in the hospital, they were confused, and the paraneoplastic panel was sent, NTO was positive. That's understandable because of the underlying cancer, but it wasn't really causing the neurological problem. When you look into the chart and you dig deeper, you'll notice that, well, the patient had normal MRI, the spinal fluid was normal, they had a bad UTI, and they actually improved when the UTI was treated, but at the same time, they were also given immunosuppressive therapy. And so you have to keep in mind some of these pitfalls as well. Some antibodies against neuronal surface antigens are known to be highly clinically relevant, like, of course, the NMDA receptor antibody or LGI1 and so forth. And when you find those antibodies positive in the right clinical setting and you're confident with the encephalitis diagnosis, then you know that this is likely clinically relevant and this will lead you in a different way. Some antibodies, the titer is important, like GAT65. Well, was it a low titer GAT65 or was it a high titer GAT65 antibody? Because low titers usually are not clinically relevant to autoimmune encephalitis. And then there's a number of antibodies against synaptic antigens that are really not highly clinically relevant when it comes to central syndromes. They might be clinically relevant to peripheral syndromes, but not really to autoimmune encephalitis. And sometimes the panel is positive. The clinician on the inpatient side is not familiar with which ones are more relevant than others and blames everything on that antibody while maybe there is an alternative diagnosis. Maybe the patient had vasculitis or neurosarcoidosis or something not even immune mediated at all. And this positive antibody was just clinically irrelevant. We frequently see this with the voltage-gated calcium channel antibody, acetylcholine ganglionic antibody, low titer GAT65, as I mentioned, and also sometimes with VGKC antibody when LGI1 and Caspr2 antibodies are negative. Some of these antibodies, as mentioned, they might be more relevant to peripheral syndromes, for example, Lambert-Eaton myasthenic syndrome in case of voltage-gated calcium channel or acquired autoimmune dysautonomia in case of acetylcholine ganglionic antibody. But for central syndromes, you really have to reevaluate and see if really this antibody is relevant to the picture you're dealing with. One tool that can help in determining the clinical relevance of the antibody is the Neuronal Autoantibody Confidence Scale. This is a scale that we worked on a few years back with Dr. Probasco and Dr. Michael Levy from Johns Hopkins. We looked at patients who were diagnosed with autoimmune encephalitis or related paraneoplastic syndrome, and patients in whom this was suspected, but eventually another cause was found. But during the evaluation, neuronal antibody panel was sent. And then we looked at the rates of positivity here. So we looked at those patients who tested positive, but eventually were diagnosed with an autoimmune encephalitis or a paraneoplastic syndrome, and those who tested positive, but eventually were diagnosed with something different. And we tried to look at the differences between the two groups. And then we came up with the scale. And as you can see here, if you score 2 or more on this scale, you're more likely to have a clinically relevant antibody. While if you score below 1, you're more likely to have a clinically irrelevant antibody, while a score of 1 is not really predictive. The patients gets 1 point if they have an antibody against intracellular antigen or a highly clinically relevant surface antibody. If they presented with a movement disorder, if they have cancer or smoking history, if they had inflammatory CSF, or if they had concomitant hyponatremia, while 1 point is deducted if the clinical course was chronic. So we still trying to validate this scale in a larger group of patients, but we actually use it frequently in clinical grounds, and it's been very helpful in determining whether this antibody is relevant to the clinical picture or not. So this is basically the possible scenarios that you will face when you receive the patient in clinic. The neuronal antibody might be positive for an onconeuronal antibody, likely clinically relevant. Here you want to do see if the cancer was treated or found. If not found, then you'll decide on the cancer screening. Periodic cancer screening needs to be more strict, more frequent, and for a longer period of time. And you try to avoid long-term immunosuppression so as not to lead to progression of the underlying cancer, but you still would treat acute relapses or worsening with steroids and or single or limited doses of cyclophosphamide. If the neuronal antibody was positive for a highly clinically relevant neuronal surface antibody, then you will assess if this patient needs long-term immunosuppression based on rate of recurrence and many other factors that we will cover in the next slides. And you'll also decide on the need for periodic cancer screening based on the specific antibody, because we know the neuronal surface antibodies, some of them are more linked or more frequently linked to cancer than others. And then the third possibility is having one of those low clinical relevance neuronal antibodies. We usually do the neuronal antibody confidence scale. We run it, we look at the charts more carefully, look to see if anything was missed, any test that needs to be done, and maybe other etiologies could explain the clinical picture. Sometimes we do find alternative diagnosis, sometimes we don't, and if we don't, and there's no better explanation, we just treat this antibody like we do the highly clinically relevant ones. And then the fourth possibility is that all the neuronal antibody panels came back negative, both from the serum and the CSF. And here you have to evaluate, am I dealing with a clinically definite seronegative autoimmune encephalitis? And really, by saying so, the only subtype that you can say with confidence that is definite in the setting of negative antibodies is limbic encephalitis. So if the patient meets the Grouse criteria from 2016 for seronegative limbic encephalitis, you have more confidence that this was autoimmune encephalitis of the limbic subtype. You also will evaluate, do they meet criteria for probable seronegative autoimmune encephalitis, meaning that they had both abnormal MRI and CSF in the setting of a clinical picture suggestive autoimmune encephalitis and negative neuronal antibodies. And then you'll evaluate, do I need long-term immunosuppression? Do I need cancer screening? And we'll touch base on how to make those determinations in the next slides. And then some of your seronegative patients, when you look at everything that was done, they actually do not meet criteria for limbic encephalitis or even for probable seronegative autoimmune encephalitis. And in that case, again, you need to go back and reevaluate for other etiologies before making the diagnosis of seronegative autoimmune encephalitis. Another helpful scoring scale is the AE2 score that was proposed by Dr. Dobey and the Mayo Clinic group. And this scale, we find it also very useful in clinical practice. This scale is actually used a little bit earlier in the evaluation of the patient, and it's a scale that you can use to determine whether it is even worth it to send the neuronal autoantibody and whether you predict it to be positive. As you can see, it uses certain factors that are very common in the autoimmune encephalitis presentation. Things like having facial-brachial dystonic seizures, refractory seizures, new onset movement disorders, inflammatory CSF, typical MRI findings, presence of cancer, and other clinical factors. And it gives a weighted score for each of these factors. And then the higher the score, the more likely that your neuronal antibody panel will come back positive. So this can help you in selecting patients to even send the scale so you wouldn't end up with a confusing result at the end. This score can also be used to make the diagnosis of autoimmune encephalitis. And here's an example of how to do that. If your patient scores above 4, then they have possible autoimmune encephalitis. If they score above 4 and the panel comes back positive, here you have confidence in making the diagnosis of a seropositive autoimmune encephalitis. If the panel was negative, but the patient scored above 7 or scored above 4 and had good response to immunotherapy, then this is probable autoimmune encephalitis. So this is an easier way to make the diagnosis either in clinic or in the hospital for some patients who have a more prolonged or protracted hospital course. Sometimes the neuronal autoantibody is negative, but the patients have some other antibodies that may be implicated in the neurological presentation. The most frequent antibodies we see in that setting is the thyroid antibodies, anti-TPO and anti-thyroglobulin antibodies. These are two antibodies linked to Hashimoto's encephalopathy, which we currently refer to as SREAT, or steroid responsive encephalopathy associated with autoimmune thyroiditis. The clinical relevance of these antibodies is still being explored. There's some recent work from Dr. Delmau's group that showed that they really lack disease specificity. You can see them in people with a typical SREAT picture, but also in many other control groups who do not have the SREAT picture. However, in clinical practice, this is actually not uncommon to see patients with SREAT either on the inpatient side or in the autoimmune encephalitis clinic. These are patients who typically have a normal brain MRI. Their neuronal antibodies are negative, both in the serum and CSF, but they show dramatic response to steroids, and they typically present with either new onset seizures, new onset movement disorders, stroke-like episodes, or some psychiatric symptoms, including hallucinations. The other type of antibodies that we also somewhat frequently are seeing in the autoimmune encephalitis clinic is antibodies against dopamine receptors, D1, D2, and tubulin antibodies. They come within the Cunningham panel, which is a panel that is mainly used by pediatric neurologists for patients, children with PANDAS and PANS. But we're seeing more and more adult onset PANDAS and PANS-like conditions. PANDAS stands for Pediatric Autoimmune Neuropsychiatric Disorder Associated with Streptococcal Infection, and PANS is Pediatric Autoimmune Neuropsychiatric Syndrome that is not necessarily linked to streptococcal infection, maybe to viral infections or just idiopathic. And we're seeing more such patients, especially in young adults coming to clinic. Keep in mind that these patients will have a lot of psychiatric symptoms. It's actually part of the syndrome. They develop acutely. They make the patients anxious and obsessed, and this can cloud the clinical picture, as we will talk later in the slides. But these are a little bit more atypical antibodies that we're seeing in clinic, and they're a little bit harder to deal with and to put a management plan and make the diagnosis with more confidence. But I think autoimmunity plays a role in these two conditions, a significant role, and they should not be overlooked. All right, so now you evaluated the antibodies. You are more confident in the diagnosis of autoimmune encephalitis. What's the next step? Well, the patient is on 60 milligrams of prednisone, and you're now the managing physician. You want to do, what are you going to do with the prednisone that the patient is on? Well, the first thing to pay attention to is that rapid interruption of immunotherapy can lead to early recurrences in autoimmune encephalitis, similar to what we see in other antibody-mediated disorders like neuromyelitis optica, for example. So the recommendation is not to abruptly stop immunosuppressive therapy or immunotherapy in general. If you want to wean down prednisone, try to wean it down as slow as possible, as long as the patient can tolerate being on steroids, and also depending on which antibody is positive. Some will require more slower weaning. Some patients come with planned periodic intravenous methylprednisolone or IVIG in lieu of oral prednisone. And again, you have to determine how long am I going to continue this, and am I going to increase the interval between these infusions, and how am I going to wean off the dosing. The most important thing while weaning bridging therapy is to look for relapses. If the patient relapses while weaning steroids, that already tells you that this patient likely needs a steroid-sparing maintenance immunosuppressive therapy. And that's really the best way to make that important determination regarding a long-term immunosuppressive therapy. Other factors other than having an actual relapse, you might look at what is the antibody and what was the severity of the clinical picture. Some patients with very severe initial presentation, like an NMDA receptor encephalitis, for example, you might want to suppress them for a longer period of time, because early recurrences usually happen right after the index event. If you're dealing with a seronegative autoimmune encephalitis, for example, you're less confident that this is going to be a recurrence, so you want to be more conservative when it comes to establishing long-term immunosuppressive therapy. What about cancer association? Does this patient have cancer? Is this paraneoplastic encephalitis? Should I worry about immunosuppressing someone with cancer? Maybe the underlying cancer will get worse if I do. So those are patients that are better avoided in terms of putting them on long-term immunosuppressive therapy. What is the patient's comorbidities? What type of work do they do? Do they work in a hospital? Are they going to be at a higher risk of infection? Are they otherwise healthy and maybe they can tolerate long-term immunosuppressive therapy for a couple of years? These are all factors that the clinician have to factor in when making this very important and complex decision. Now, because there's really no solid data to guide us clinicians on what to do with how to select patients for long-term immunosuppressive therapy in autoimmune encephalitis, unlike for example, in MS, you know that you'll put your patient, once you make the diagnosis, you'll put the patient on long-term immunomodulation. But in AE, you're less confident. The published relapse rates for autoimmune encephalitis, they really don't exceed 30 to 35%. So most patients will have a monophasic course. So how can you select those patients for long-term immunosuppression? Because of this, in this recent manuscript that was recently published by the Autoimmune Encephalitis Alliance Clinician Network Group, we used a survey. We sent a survey to all participating members, asking them about their approach to management of autoimmune encephalitis, both in the acute setting and the long term. And this is one of these, this is actually one of the most important questions that were included in the survey. And this was check all that apply type of question. And the question was, which of the following clinical scenarios you would choose for long-term or maintenance immunosuppression? And as you can see here in the responses from the members of the Alliance Clinician Network, you'll see that the one scenario that most clinicians agree that they will suppress patients' immunity long term is the scenario in which they have a clinically relevant neuronal surface antibody, and they already had at least one relapse after the index event. So after the second relapse, 70% of clinicians chose to use long-term immunosuppression in this clinical scenario. However, about 50% chose to put the patient on long-term immunosuppression if they have a clinically relevant neuronal surface antibody, even after a first attack, in order to prevent any early recurrences. In case of relapsing seronegative autoimmune encephalitis, about 60% also chose long-term immunosuppressive therapy, while monophasic seronegative autoimmune encephalitis, really only 10% said they would consider long-term immunosuppressive therapy in those patients. What was more divisive was the use of long-term immunosuppressive therapy in paraneoplastic encephalitis. As you can see, if tumor was found and treated, only about 25% of clinicians indicated they would use long-term immunosuppressive therapy in that situation. Obviously, you don't want to immunosuppress someone with an underlying cancer so the cancer wouldn't get worse. However, if tumor was not found, we really couldn't get a consensus on what to do in that situation. Many clinicians were really hesitant to choose a long-term immunosuppression if the patient has an antibody against intracellular antigen because of their strong link to cancer. So maybe we can't find the cancer now, but it will happen in the next few months or the next few years. And putting someone like that on chronic immunosuppression might lead to acceleration of the underlying cancer, which of course is not what we want to do. As for what agent to choose for long-term immunosuppressive therapy, rituximab was the most popular, and this was kind of a question without specification of which type of autoimmune encephalitis are we dealing with. You can see here that some clinicians chose mycophenolate and azathioprine. Many clinicians said that really their choice will depend on what type of antibody are we dealing with, what type of autoimmune encephalitis are we dealing with. If it's, let's say, seronegative autoimmune encephalitis, maybe you want to use something more broad spectrum like mycophenolate, while if it is something that is known to be antibody mediated, then rituximab might make more sense. You can actually see here that cyclophosphamide was actually not used by any member as a long-term immunosuppressive therapy, and I think this answers a question that Kim had earlier in the meeting. Because of the risk of possible cancer and severe immunosuppression, it is not a preferred agent for maintenance immunosuppressive therapy, but it can be used as a second-line agent in the acute setting, especially in paraneoplastic and T-cell mediated autoimmune encephalitis. As for the duration of long-term immunosuppressive therapy, again, lifelong immunosuppression was really only chosen by 7% of the members. It's not popular, again, because this condition is not known to be really highly recurrent. Autoimmune encephalitis is monophasic in most patients, at least based on the available evidence that we have currently. Many clinicians, about 44%, chose immunosuppression for 3 years, then careful withdrawal of immunosuppression. And then many clinicians indicated that really, again, this is an individualized decision depending on what is the antibody, what are the comorbidities, what is the likelihood of cancer, and so forth. So after you made the determination of whether or not you're going to use long-term immunosuppressive therapy and how fast you're going to wean bridging immunosuppressive therapy, the next question is, okay, do I need to repeat periodic cancer screening, and how frequent and for how long? If the patient has paraneoplastic encephalitis with a known cancer or cancer that was found during the acute hospitalization of the index event, then the surveillance of that cancer after treatment is determined by the oncologist. There are established guidelines for each cancer, and it's really not the job of the neurologist anymore. However, if the patient had one of those commonly paraneoplastic antibodies, anti-HU, anti-RE, and so forth, but no cancer was found, then you want to be a little bit more stringent. You want to do the periodic cancer screening more frequently, 6 months or at least once a year for at least 4 years, according to some recommendations that were published by the European Task Force by Dr. Titulaire and Dr. Dalmau in 2011. And most of us, I think, would follow that same stringent periodic cancer screening. You can use either a CAT scan based or whole body PET screening if approved by insurance. And I know we talked about this in previous lectures, and sometimes it's a struggle to get PET scan approved. PET scan is more sensitive to look for early cancer, especially that in most cases with paraneoplastic syndromes, the cancer is really early and small, and that's why it was missed during the acute hospitalization. So when you do this periodic screening, a PET scan might be a higher yield, but sometimes it's hard to get it approved. And then we do a CAT scan based screening in that case. If the patient has a known paraneoplastic syndrome and is showing significant worsening of their neurological presentation or a definite neurological relapse, then you want to repeat the cancer screening again at this time, because this might indicate return of cancer. How about neuronal surface antibodies, and how about seronegative autoimmune encephalitis? In these situations, the link to cancer is less strong. How frequent are you going to do the cancer screening? Again, because there's no solid data, we included this as one of the questions in our survey to the Autoimmune Encephalitis Alliance Clinician Network members. And for that first graph here, you see it on your left-hand side. This was someone with autoimmune encephalitis and neuronal surface antibody. How frequent and for how long would you do cancer screening? And you'll see here that most clinicians, again, they really chose a more individualized approach depending on the type of antibody. We know that some surface antibodies are more strongly linked to cancer, like AMPA and GABA-B, for example. But in general, many clinicians felt that they need to do periodic cancer screening either annually or 6 monthly for 4 years, given that cancer is still possible with neuronal surface antibodies, while no screening was not really a very popular choice, as you can see here. For seronegative, clinically definite limbic encephalitis, most clinicians felt the need to do at least annual screening for 4 years, given that limbic encephalitis can be frequently paraneoplastic in nature. As for other seronegative anatomical variants of autoimmune encephalitis, like seronegative cortical encephalitis, meningoencephalitis, striatal encephalitis, diencephalic or brainstem encephalitis, clinicians felt less need to do frequent and prolonged cancer screening in those situations. And the most popular choice was really doing an annual screen for 2 years after the index event. If the patient has a post-herpetic autoimmune encephalitis, since you have a known trigger, there was almost a consensus between clinicians that really no additional screening is needed for cancer beyond the initial cancer screening that was done during the index event. As for iatrogenic autoimmune encephalitis, and here we only refer to medications like tumor necrosis factor alpha inhibitors or other immunomodulating therapies that can trigger CNS inflammation like autoimmune encephalitis. Many clinicians did not feel that there is really a strong need to do prolonged or very frequent cancer screening beyond the initial screen. That's because there's a known trigger here that triggered the autoimmune encephalitis. However, it looks like the confidence in that recommendation was less so compared to post-herpetic autoimmune encephalitis. So still, some clinicians felt that there is still some need to do periodic cancer screening in those patients. Of course, this excludes patients who have iatrogenic autoimmune encephalitis secondary to immune checkpoint inhibitors. Those patients obviously already have a known cancer. That's why they were given immune checkpoint inhibitors, and cancer screening, again, will be dictated by the oncologist. So once you made that determination regarding how the periodic cancer screening and the long-term immunosuppressive therapy, and you evaluated the confidence in the original diagnosis, I think the most important role of the outpatient neurologist here is treating residual symptoms in autoimmune encephalitis. And today I will share with you some kind of interim data analysis from our patients from the autoimmune encephalitis clinic that we just started in the University Hospitals of Cleveland. We have data from the first 46 patients referred to the clinic, and we were specifically looking at residual symptoms after recovering from the acute index event. What are the residual symptoms that we're seeing? And we had to exclude 13 patients because the diagnosis was either questionable, or we already found an alternative diagnosis, or there was insufficient follow-up, or they were referred for neuronal antibody-associated peripheral syndrome rather than autoimmune encephalitis. Of the remaining 33 patients, 57% of them were seropositive, 27% were seronegative, and 15% had SREAT, or steroid-responsive encephalopathy associated with autoimmune thyroiditis. We had a mixed bag of antibodies. Some were highly clinically relevant neuronal surface antibodies, some were onconeuronal antibodies, some with low clinical relevance neuronal antibodies, and even some atypical antibodies like anti-dopamine receptor and antithyroid antibodies, as mentioned earlier. The average age of the group, 45 years, majority were females, and the average follow-up we have on those patients is 21 months after the acute index event. The etiology was idiopathic in 54%, post-viral in 15%, iatrogenic in 15%, including immune checkpoint inhibitors, and paraneoplastic in 12%. And here we're excluding the ones on immune checkpoint inhibitors so as not to be counted twice. The recurrence rate in this group was 35%, meaning that, again, the majority of patients had monophasic course. And of course, we have a short duration of follow-up, so these numbers might change the longer we are following up the patients. But again, the 35% recurrence rate is really similar and concordant to previous reports in autoimmune encephalitis literature. And this is the data that we have so far from these patients. You can look at this table. We categorize the symptoms, as you can see here on the left-hand side. And the first column, the second column will have the percentage of these symptoms in the acute attack, during the acute attack, and then what's the frequency of those symptoms during the first outpatient follow-up, and then again in the latest outpatient follow-up that we have on each patient. And then we also looked at the percent improvement. So how many of the patients who had, let's say, cognitive symptoms reported improvement in their latest outpatient follow-up of the cognitive symptoms. And that's that last column that you see over there. And I'm not going to read this line to line, but I just want to point out a few important points here. First of all, you see that there is significant improvement in almost all symptoms, even during the first outpatient follow-up. And the more improvement is expected the longer you follow the patient. So there is room for improvement over time, as you can see from these numbers. For example, for cognitive symptoms, 54% of the patients had cognitive symptoms during their acute attack, but during the first outpatient follow-up, only 39% had cognitive symptoms. And during the latest outpatient follow-up, only 27% had cognitive symptoms. And then 72% of patients who had cognitive symptoms reported improvement. Some other important things to note from this table, you'll notice that some symptoms usually resolve almost completely or near complete resolution, like speech symptoms, for example. Most patients will have significant improvement in their speech symptoms. Consciousness and alertness impairment, obviously almost all patients will recover their conscious level by the time they come for follow-up. Psychosis actually improves in 94% of patients. So again, although a common symptom during the acute setting, usually residual psychosis is very rare after immunotherapy in the acute setting. Dysautonomic symptoms also, most patients will recover this at the time of their latest follow-up. The symptom that we see the least improvement was actually sleep disorder symptoms. So you see that only 40% of patients reported improvement in their sleep disorder symptoms in their latest follow-up. Something like behavioral changes. If behavioral changes was part of the original or the initial manifestation, only 58% of patients reported improvement in their behavioral symptoms at the time of the latest follow-up. either by report of the patient or the caregivers, obviously. One other thing to note here is that you can see seizures, only really 9% of the patients reported residual seizures in their latest outpatient follow-up. So this again tells you that immunotherapy is really usually successful in achieving seizure freedom in most of our autoimmune encephalitis patients, and many of them do not require long-term seizure medications, and we'll touch on this in the next slides. And also there's some significant improvement in movement disorders as well, with the exception of spasticity and tic disorder, and we'll touch on that. We also evaluated the utilization of the multidisciplinary team and the autoimmune encephalitis clinic so far, and we evaluated the percentage of patients that were referred to other collaborators who work with us in the autoimmune encephalitis clinic. The majority of referrals were to movement disorder specialists, and this is a little bit skewed because our clinic is actually has a focus on autoimmune movement disorders, so that kind of almost goes without saying that they will be evaluated for movement disorders. But the second most common specialty that we reached out to is psychiatry, 27% of patients, clinical pharmacy to help with immunotherapy dosing and monitoring, 21%, psychology, and 18%, oncology for paraneoplastic syndromes. Neuropsychology, actually, we referred patients, only 15% of patients. That was actually a little bit surprising to us. We thought that we utilize this a little bit more frequently, and I think that's why we do research, to see where our shortcomings and what we can improve. And I think we definitely can utilize more neuropsychological rehabilitation for our patients. Neuro-ophthalmology, we frequently require their help, especially because a lot of our patients will also have either optic nerve involvement, or sometimes cancer-associated retinopathy is not infrequent in some of our patients. Endocrinology, they usually help with our street patients, especially if they have clinical hypothyroidism. Autonomic specialists, we sometimes utilize our autonomic specialist experts, especially in patients who have significant residual postural hypotension or symptomatic POTS or symptomatic arrhythmias. Infrequently, we use the help of our epilepsy colleagues. Obviously, the rate of residual seizures is low and usually is easy to manage by the neuroimmunologist. But in some situations, when there is refractory seizures or highly recurrent seizures, we might need the help of an epilepsy expert. And luckily, we have a few epileptologists who are actually interested in autoimmune epilepsy, and I think more and more epileptologists are becoming interested in that field. So this will also help provide better care to our patients. Behavioral neurology or dementia neurologists, we rarely need their help, but sometimes we do, because some patients who have significant cognitive impairment after the acute attack, especially older patients, they might actually benefit from some of the resources that are available to our behavioral neurology colleagues. And then finally, neuro-oncology. Keep in mind that some of our paraneoplastic encephalitis patients, they already have brain metastases, and some of the neurological symptoms, when they happen, you're not sure, is this because of return of encephalitis, or is this because of the brain metastasis? And definitely you'll need the help of a neuro-oncologist in this situation. And many neuro-oncologists in other institutions actually are the primary caregivers or the primary providers for paraneoplastic and autoimmune encephalitis syndromes. So we'll just talk a little bit briefly about the details of those residual symptoms. Residual cognitive symptoms that we're seeing in clinic, definitely memory impairment is one of the commonest, especially after limbic encephalitis. We're seeing impairment in almost all other cognitive domains, including attention, executive function, language, and visuospatial function, as also discussed by many of my colleagues and previous speakers in this session. Keep in mind that mood disorders can also contribute to cognitive symptoms. So maybe if there is untreated mood disorder, you might want to start with that in order to improve cognition. And then again, the utilization of cognitive rehabilitation may be helpful, but it does require more research to really show the value of this intervention. We've seen some significant improvement, especially in our younger patients after cognitive rehabilitation, but still not everyone is open to the idea of seeing a neuropsychologist almost on a daily basis, or having an occupational therapist goes to your house and watch you while you eat. So we do have some problems in committing or signing up for that. I think we also need to do a better job in referring more patients who can benefit from this intervention, and also hopefully do more research to really evaluate and quantify the benefit from this intervention. Psychiatric symptoms, mood disorders are very common as residual symptoms. Sometimes patients will develop PTSD just from the fact that they were in the hospital for a month or 2 months, and they don't know what was happening, and they missed their exams, they missed family occasions and things like that. We're seeing a lot of OCD-like symptoms, and especially in street and in pandas patients, because this is actually part of the disease. You develop acute psychiatric symptoms as part of the autoimmune process. It's not uncommon that these patients will express a lot of anxiety, a lot of OCD behavior, including somatic obsessions. So they will look like someone with a functional neurological disorder. They can actually develop a functional neurological disorder that coexists with pandas or PANS or street. So keep that in mind, because this, of course, makes it a little bit difficult when they come with new symptoms. Is this a true relapse? Is this just stress related? Did I make the right diagnosis in the first place? Or maybe this is a primary psychiatric disorder. But there are so many things to look into and to rely on. The CSF results, the presentation, was there true seizures or not? Was there involuntary movement that happened acutely with the psychiatric symptoms? So it is very important not to let those somatic obsessions or those somatization syndrome-like symptoms in these patients distract you from the fact that there's an underlying autoimmune process going on that might need to be treated and relapses be attended to when needed. But of course, involvement of a psychiatrist is very imperative in those cases in order to treat the coexisting psychiatric symptoms or residual symptoms as well. Now, keep in mind that residual psychosis is rare. So if you see something like that, you really have to kind of revisit the diagnosis. Was it really an accurate diagnosis, or are we dealing with a primary psychiatric disorder? Movement disorders, almost all types of movement disorders can happen in the setting of autoimmune encephalitis, especially when it's diffuse or multifocal. Then you have to think of autoimmune encephalitis. Most neurodegenerative movement disorders have more gradual and chronic course, and most vascular or demyelination-related movement disorders have an acute or a sudden onset. While if you have acute onset of a diffuse or generalized or multifocal movement disorder, really autoimmunity, especially autoimmune encephalitis, becomes one of the highest possibilities in those patients. Luckily, however, most of these movement disorders respond very well to immunosuppressive therapy in the acute setting while the patient is hospitalized. And by the time they come to the outpatient clinic, there's really no or only minimal movement disorders left. What we've been seeing is mainly tic disorder. We see a lot of residual motor and vocal tics after autoimmune encephalitis attacks, especially pandas and PANS. And we're seeing spasticity, especially in patients who presented with an encephalomyelitis picture. So there was inflammation of both the brain and the spinal cord, or there was involvement of the brain stem. Then the pyramidal tracts are commonly involved, and we've seen some significant spasticity developing, like after GFAP, encephalomyelitis, for example, and other similar conditions, of course, in stiff person syndrome as well. Seizures, as mentioned, most of the focal seizures that happen in the setting of autoimmune encephalitis are responsive to immunosuppressive therapy, and you might be able to actually wean those patients off seizure medications as long as they have been seizure-free for a good period of time. Their MRI is normal, their EEG is normal, then you feel more confident in weaning those patients off seizure medications. While patients who actually develop some structural tissue loss, we know that some patients might, after limbic encephalitis or after LGI1 syndrome, for example, they can develop acquired mesial temporal sclerosis or significant hippocampal atrophy. These patients, at least in our clinical experience, they are more likely to require long-term seizure medications. Also, patients who presented with new onset refractory status epilepticus or NORS, most of these patients will require long-term seizure medications, and many of them will have recurrent seizures based on published data so far. Dysautonomia, luckily most dysautonomic symptoms resolve, so we don't see it in clinic as much. When we do see it, we mainly see residual postural hypotension or symptomatic POTS. Sometimes some bladder dysfunction is still there. Sometimes we, as neuroimmunologists, we can manage this, and sometimes it gets too complicated and you might need the help of an autonomic specialist, as mentioned. Sleep disorders tend to persist. So if it was part of the initial presentation, sleep dysfunction might persist in the chronic phase. And again, you might need the help of a sleep specialist, or you might be able to treat this yourself depending on the complexity of the residual sleep disorder. In our recently published paper on the recommendations for symptomatic and long-term therapy, we had a table there that kind of discusses some of the symptomatic treatments that can be used for autoimmune encephalitis, a myriad of symptoms. These medications can be used both in the acute setting and also in the long-term management of residual symptoms. And you can see here, there are many classes available: benzodiazepines, antipsychotics, mood stabilizers, and antidepressants for psychiatric symptoms. But keep in mind that some of these medications can have some side effects in your autoimmune encephalitis patient, especially in MDA, for example. They can be sensitive to antipsychotics. I think Dr. Ding discussed this in more detail in his presentation. Also, if the patient is still dysautonomic, you want to be a little bit more careful with antipsychotic use. If they have seizures or they have significant brain atrophy, you might want to be careful with the antipsychotics that lower seizure threshold and so on. For seizures, some evidence suggests that sodium channel blockers like lacosamide and carbamazepine might be more effective for LGI1 antibody encephalitis. So there are some factors to consider when selecting medications. However, as mentioned, many patients will not require long-term seizure therapy after the acute attack, but you have to do the weaning very carefully and be very careful and reinstate anti-seizure medications if needed in case of recurrent seizures. Movement disorders, as mentioned, we can use anticholinergics for dystonias, benzodiazepines for dystonias, spasticity, catatonia, stereotypies, and hyperkinetic movements in general. Muscle relaxants also can be used for spasticity and dystonia. We use dopamine blockers for chorea and tic disorders, and dopamine agonists for acquired Parkinsonism and hypokinetic rigid syndromes. However, all of these medications can have side effects, and you have to be careful when using them. If the patient is psychotic, probably using dopamine agonists is not a good idea. If you use a dopamine blocker for chorea, but the patient develops severe extrapyramidal symptoms or neuroleptic malignant syndrome, you want to stop that right away and instate treatment for NMS and so forth. Again, anticholinergics, be careful in dysautonomic patients. For dysautonomia, sympathetic hyperdrive, we use beta blockers, alpha-2 blockers, and acetylcholinesterase inhibitors. For postural hypotension, metadrin, fludrocortisone, and droxidopa can be helpful. We've had a lot of luck with droxidopa in some of our patients. Antimuscarinics for hyperactive bladder. Again, watch for side effects. For sleep disorders, these patients might require a polysomnogram after the acute attack, and then treating the residual sleep disorder symptoms according to what symptom are you dealing with. So in conclusion, although the neurological status improves with acute immunotherapy, residual symptoms are not uncommon. Residual neurological symptoms can be managed by the neuroimmunologist, but referral to other neurological subspecialties may be needed in some cases. The role of psychiatry is pivotal in many AE patients. Also, neuropsychology should not be overlooked, especially neuropsychological rehabilitation. In some cases, we might need to work with oncologists, rheumatologists, endocrinologists, sleep specialists, and many other specialists, depending on what residual symptoms are you dealing with. Part of the long-term management includes evaluation of the neuronal antibody panels, determining the clinical relevance of the antibody, and determining the confidence level in the diagnosis of autoimmune encephalitis. Another important part is weaning, bridging immunosuppressive therapy, and then starting long-term immunosuppression if relapses occur during the weaning process, and then starting periodic cancer screening for your AE patients with a frequency and duration that will depend on the type of the antibody, and the clinical subtype of autoimmune encephalitis is also a very important part of the long-term management of autoimmune encephalitis. So this concludes my presentation, and I'll be more than happy to answer any question from you.